Hey everyone, we're going to get started in just a couple minutes here. And before we get started, we do have a poll just to kind of get an idea of where everyone is kind of in their NP journey. So if you want to go ahead and answer that for us, if you are joining us on Facebook or YouTube, you can put your answers to these questions in the chat. And we will get started in just about 7 to 8 minutes here.
Hey everyone, today we're going to be covering neuro. I'm Brittany and I'm a family nurse practitioner with Archer Review. I hope that everyone is having a great week so far, and we have a lot to cover, so let's go ahead and get started. If you have questions, there are nurse practitioners in our chat today that would love to connect with you. As always, feel free to reach out with any questions you may have. Okay, so all right, so let's go ahead and talk about those tricky cranial nerves. So we have a little mnemonic for you to help remember it. So O, to touch and feel, very good velvet, ah, heaven. Okay, so the first thing we're going to do is think about the mnemonic. And what it's going to do is it's going to give us a trick in our mind to remember what the nerve name is. Okay. So remember, these cranial nerves are our messengers of our nervous system, and they go all the way down into our head and neck. We have 12 pairs of cranial nerves, and they control sensory and motor functions. And we'll talk about that in just a minute. So, okay. The first one is going to be olfactory, then optic, so you can see how it correlates with the O's. And we're going to go through every single nerve, so don't stress too much right now. Okay, so the other thing I want to just draw your attention to is some say marry money, but my brother says big brains matter most. Now, that's another mnemonic for us to remember if the pair of nerves are sensory or if what they control or if they control motor function. So you can see if you remember this mnemonic, it's going to say S is going to be sensory, M is going to be motor, and B, like brother or brains, those are going to be both. So just as you're going through here, this just kind of gives you a silly saying to help you remember. Okay, so moving on to the first three. The cranial nerve one is going to be your olfactory. This one is tested probably the most easiest. We're just going to ask our patient to smell something. So some of us like to keep little bottles around the office that might have coffee in it or might have some peppermint in it, and just have them to close their eyes and smell. And if their smell is intact, then you know cranial nerve is one is intact. Number two, so that is going to be your optic nerve. So I want you to think about it's sensory. It helps us to see. The optic nerve is going to transmit those images from our eyes, okay? And it's going to help us with our central and peripheral vision, okay? So a lot of times what we'll do is we'll test this with like the Snellen chart, in any type of visual acuity exam that you give there. That's a really good one to test this one. And then cranial nerve 3 is going to be our ocular motor nerve. And this one is kind of like a puppeteer. It directs our eyes in where we want them to go and look at. So if I'm starting to look over here, then that's the way that I'm going to be testing that. So who can tell me in the chat some tests that we can do to test that cranial nerve 3? So who wants to put a few things in the chat of some tests that we can do? And they are on the slide, just for your reference there. So, yes, extraocular motion. So how are we going to test that? I'm going to put our finger here and ask them to trace it with just our eyes, right? That's going to be testing that 6 cardinal fields of gaze, right? Always bringing it back to the middle. Yep, you can also do an H shape with this. Yep. Or cat whiskers, as I've heard it called too. And then also anytime we write down the word perla, pupils equal round reactive delight and accommodation. So that also helps to test that ocular motor nerve. So very good. Y'all have this. So let's go ahead and move on to 4, 5, and 6. We have the trochlear nerve. And so who can tell me what the function of the trochlear nerve is? It's also for eye movements. So remember that. And you're actually going to test it the exact same with the cardinal fields of gaze. So it checks off 3 and 4 with that one. Okay. And then cranial nerve 5 is going to be our trigeminal nerve. And this is our first combination of a motor and sensory nerve. So going back to your mnemonic there. The trigeminal nerve allows us to perform movements like clenching our jaw, and it also gives us sensation like touch, pain, temperature to a large portion of our face. So a lot of times we'll ask our patients to clench their jaw. We'll have them to close their eyes. Some of you guys probably in school had the little cotton applicator and was touching different parts of your patient's face. That is how we can test that trigeminal nerve, okay? And then cranial nerve 6 is going to be our abducens, also another motor nerve responsible for eye movement. And you also can help to check this one off with the 6 cardinal fields of gaze. So again, that 6 cardinal fields of gaze test, you know, you can kind of remember that is I remember 6, 4, and 3 help me see. So I like that little mnemonic as well for y'all to jot down. Okay, let's go ahead and look at 7, 8, and 9. Let's review those. So our facial nerve is number 7. Again, this is a both. It's sensory and motor. And it gives us the ability to make our facial expressions. It even stimulates tearing and salivation. It triggers corneal reflex and controls the taste buds on those front 2/3 of our tongue. So this is like a really big deal here. If somebody has something going on with cranial nerve 7, they could be using a lot of losing a lot of different aspects of their face. So a lot of times what I like to do is have them to make a silly face, because again, remember facial expressions. They can raise their eyebrows up and down. They can smile, they can frown, they can puff their cheeks. So again, looking for anything that gives us spatial symmetry. Also, again, that cotton there on the sides of their face near their eye, that will also check this nerve, seeing if they have like some sort of blink response. So cranial nerve number 8, that's going to be our acoustic. Okay, and who can tell me where that's going to be found? So that's going to be involving our ears and our hearing, and I've put a few things on there for y'all to tell me about the tests. So this is something that we test a lot, especially in labs in advanced health assessment. So do y'all remember what it might be for number 8, how we test number 8? That's right. Renee and Weber test. That's right. So you guys remember when we talk about air conduction, greater than bone conduction, all of those little buzzwords, the Rombergs is also on this test. When they close their eyes, we're checking to see if they sway. That is how to check cranial nerve 8. So cranial nerve 9, this is also another both, so sensory and motor, and it's the glossopharyngeal nerve. And this is probably our least favorite to check, because not only do we have them to open their mouth and look at their uvula and their tongue movement, but we also need to check a gag reflex if we're going to completely check this nerve. So eliciting that with a little tongue depressor or whatever it may be, a little Q-tip, that's how to check that nerve to make sure it's completely intact. So if you're doing a full cranial nerve exam, you do need to add that gag reflex in. All right, we're going to move on to 10, 11, and 12. We have the vagus nerve. Now, this one has been a hot topic lately. Because there's a lot going on. This one here has to do with parasympathetic responses. So heart rate, breathing, digestion, and swallowing. It's pretty easy to test. You're just going to ask them to swallow, and this allows them, allows us to test that nerve. Also, how well are they speaking? That also helps us to assess that nerve as well. So it's easy. The cranial nerve 11 is our spinal accessory nerve. And you're just going to have them to shrug their shoulders. That will be helpful to check that one. And then I like to remember 12 on the glossopharyngeal, stick out your tongue, you're done. So we know that we've made it through all 12 when they can stick out their tongue. And again, that's checking that other nerve as well. And that's going to check that. And we could just, oh, excuse me, I'm sorry. We're going to check that by having them to stick their tongue out, move it side to side, and that's going to check that glossopharyngeal nerve. So we've got it 1 through 12. Again, go back and look at this. Boards do love to test on these cranial nerves. If you're doing a complete neuro exam in clinic, you will have to, go through the motions with these patients. A lot of times I'll just go through it with them so that I can stay refreshed myself. So just some practice there. All right, I love this little diagram. We had them to kind of come up with a fun little thing for all the numbers, and I think Miss Suzanne just did a great job here. And if you draw this out on boards, you'll actually see where all the nerves go. So I love to see just a quick way to work those nerves out. All right, so let's go ahead and get into some of our conditions. One of the things that we're going to talk about today in neuro is trigeminal neuralgia. So this one affects cranial nerve 5, okay? And a little pop quiz, which one was that, right? And this one here is going to have severe stabbing on the face, mouth, temple, and nose. It's known as trigeminal neuralgia, okay? And the main thing is this one is going to cause a lot of pain. So we're going to give them some anticonvulsants, but also treat your patients for their pain. So gabapentin, that's going to help with, nerve pain. Baclofen, muscle relaxers, clonazepam or clonidine, those are helpful with this right here. A lot of times we'll get these attacks in folks over the age of 50. They're sudden and severe, and this creates a lot of stabbing pain. So just paying attention to that. Physical exam findings can be hard to catch unless you're actually witnessing an attack. So the hypersensitivity will be your best clinical clue here, quite honestly. You can order an MRI or CT, but not much is going to show in trigeminal neuralgia, but you can rule out some other more severe things, okay? So let's move on. Let's talk about headaches. So just a quick refresher from our slide. You can have primary, you can have secondary. So that's going to be differentiated from either no underlying cause or an underlying cause for the secondary, or you can have acute or chronic. So just a reminder here, chronic is going to be classified as 15 headaches per month times 3 months, okay? And acute headaches can just be a few hours to days, okay? We know that headaches, they can be really hard to work up in primary care because it could be anything from just a sinus infection all the way up to meningitis, all the way up to something like cancer. So we really need to pay attention to asking them about their frequency, their duration of their headaches, where the pain is located at. So this is just something that really needs a good assessment when somebody comes in complaining of a headache, okay? And you can get more guidelines on this from the International Headache Society. That's where the definition from 15 headaches per month times 3 months comes from. So let's just talk about some of the few ones that we'll see probably in boards, but definitely in primary care. Okay, so migraines is first up on our list. So remembering, a lot of times female patients, they can be triggered. Everybody has a different trigger is what I've found. It can be anything from chocolate to bananas to I didn't sleep well last night, artificial sugars and dyes, smoking and alcohol. Really all these things can, trigger migraines. Everybody has a different thing. Perfumes. I have some patients that can't take any perfumes. That'll trigger a migraine attack for them. Some of the characteristics, auras, not everyone has aura that has migraine, but sometimes patients will describe, seeing or smelling something, more heightened awareness of the aura. Flashing lights, they might have, photosensitivity. They're going to be sensitive to the sound, pounding headache. It's usually going to be on one side. That also is another differentiator. And again, we can scan them to check for more severe things, especially if they're starting to have those chronic headache complaints, right? We need to really rule things out. And then depending on how often they're getting these migraine attacks, we can prescribe abortive or preventative medications, okay? So really just paying attention to knowing that your triptans are going to be your first line here. That's going to be more of your abortive medications. They might take something like their Maxalt, right, when they get a headache. Some of them might be taking ibuprofen. Again, always watch for kidney function with NSAIDs. But they're going to take something abortive. But if we're starting to have a lot of migraine headache days every month, especially crossing over, getting towards that 15, then we need to start looking at preventative medications, which is going to be something that they take every day. I've listed some of them here for you: topiramate, Elavil. We can use different drug classes here. I've even seen verapamil given before. So really, these are folks that we really want to try to help and mitigate their pain-free days so that they can kind of go back to function. Okay. All right, let's talk about cluster headaches. So who can tell me why they're called cluster headaches? Does anybody know? Does anybody know? Give you a minute to reply. Y'all can look at the slide. It's okay. So yes, absolutely. Frequency is clustered. So the characteristic sign is these are occurring about the same time every single day. So they do affect males more than females. Can be a genetic link or predisposition to this: alcohol and smoking. So these are going to be 10 out of 10 unilateral pain, and they may complain of things like a runny nose, eye swelling, facial droop. These are very, very painful. We're going to give them a calcium channel blocker. We're going to give them some oxygen. Of course, we're going to run some imaging, and we're probably going to give them something prophylactically like a corticosteroid or something so that they can keep these headaches at bay, because again, they're very, very painful. Okay, they can have these attacks. They can kind of come and go. I've had patients that go, 9 months between attacks, and then other patients, they seem to have attacks more frequently. So this is just something to kind of be aware of, that you'll see in addition to migraines. Okay. Tension headaches, let's talk about those. So those are going to be your most common headaches in primary care. Patients come in, they talk about some sort of tightening band around their head. They've been stressed. They have, maybe anxiety, maybe they're studying for their boards exam. Something is going to give them a headache, okay? And really and truly, the main thing is just differentiating those red flag symptoms if we need to order imaging or not. Most of the times we don't. These can usually be, managed outpatient with things like NSAIDs, Tylenol. We're going to give them a hot bath or whatever they do to try to relieve the stressor. So that's the main thing for the tension headaches, okay? And the red flags. So talking about when do they need immediate either referral to the ER or neurology, or when do they need an immediate workup for something more severe. With imaging, it's going to be complaints of worst headache of my life. You never want to hear that in primary care. Never want to hear that anywhere. A thunderclap headache, which is like a sudden severe onset of a headache. This hadn't been occurring for weeks or months, or they've had migraines since they were 14. This is something that is new onset and is very severe, especially aged 50 plus. If they start having things like neck stiffness with their headaches, what's that going to probably tip us off to? Something like meningitis, right? Pregnancy, they never had headaches before. Yep, sure, it could just be hormones, but I don't want to just reassure them in my office. I need to, get them on over, get them a little bit further of a workup, okay? And of course, anytime we have neuro changes, so if you're going to do a neuro exam on these patients and they are complaining of a headache today, and they think it's just a migraine or think it's just a tension headache or whatever because they've been stressed out, but we start seeing some of those neurological changes, we could be having things like stroke or other things that can be causing like the altered mental status there that I've listed for you all. Those are going to warrant immediate referral and workup. So just some things to be aware of on this page, mainly, if nothing else, for real life practice. This is something that you will see from time to time, and we always need to know when to refer. That's our number one goal for everything, is keeping our patients safe and know when to refer. So we're just going to move on now. We're going to talk about multiple sclerosis. Okay, this is an autoimmune system. It's autoimmune, and it happens in the central nervous system. It attacks the myelin sheaths of the spinal cord. Oftentimes, patients will have little episodes of relapse and then like a remission, and then they'll get another relapse. Of course, function maintenance is the number one goal with anybody with MS because this is progressive. We will see things like visual changes, bowel and bladder retention, changes in their deep tendon reflexes, they're overactive, double vision, gait or coordination abnormalities. This one's a really hard one to diagnose. They're going to be diagnosed in neurology for this. They're going to get an MRI. They're going to get a CT scan. They may analyze their CSF via lumbar puncture. And the main thing, again, like I said, is symptom management, trying to get them to go further and further between relapses because it is progressive. There's no cure for this, unfortunately. Bell's palsy, this one here is going to be something that, again, can be painful, but you're going to see more of facial paralysis. They're not going to be able to blink, smile. They're going to have a decreased taste. They're going to have decreased tear production. Their eye may not close all the way, so you can have things like corneal abrasions with this one. So we want to always encourage them to have eye patch and artificial tears. This can be treated with antivirals and corticosteroids. Multiple contributing factors include viral infections, pregnancy, elderly people. We're going to confirm the diagnosis mainly as a rule out because we need to rule out stroke because anybody who has facial droop on one side, that needs to be worked up to make sure that we're not having any type of stroke going on. Okay, let's talk about polymyalgia rheumatica. This is an inflammatory process causing muscle pain and stiffness in older people. I do have a slide later on down the road, but who can tell me, just as a little pop quiz, what this likes to hold hands with, what condition? So I want you to think about inflammation. So not only inflammation of the joints, but also inflammation of the vascular system as well, if they go on to develop this other condition, if you will. They're often going to have some relapse and remission. We're going to treat them with corticosteroids and sometimes methotrexate. This is probably going to be managed by like rheumatology, and they are going to have those inflammatory markers up. And if you all pay attention, on the pop quiz just a minute ago, associated with temporal arteritis. So remember I said this is inflammatory, and they can also have inflammation of their vascular system, specifically like their temporal arteries up here. Okay, moving on to stroke. Again, boards love to talk about stroke. We really need to know when to refer patients, again, to keep them safe. We have our foundation of our cranial nerves and some of our other neurological disorders, and this is another big one, okay? So strokes come in two ways. They come in hemorrhagic and ischemic. And the hemorrhagic is going to be caused by some sort of bleed. And if your patient has hypertension and we're worried about strokes, this is one of the big ones. Like the main causes of strokes in hypertension is going to be some sort of brain bleed or hemorrhagic if it gets too high. Also injuries, they can have a stroke. Ischemic is definitely by far the most common form of stroke. This one's going to be caused by some sort of blockage. So they're going to have some sort of plaque break off. They're going to have some sort of blood clot somewhere that goes to their brain. And that's what's going to cut off that oxygen blood flow and cause that brain to start dying, if you will. And so, again, ischemic strokes, most common, and they're both just as bad. I would say hemorrhagic is probably more deadly. But they're both bad and can cause a lot of long-term neurological defects. So let's start with a precursor to strokes. Not everybody gets these, but TIAs, or transient ischemic attacks, sometimes called mini strokes. They'll have stroke-like symptoms that last just for a few seconds or a few minutes, and they often will resolve on their own. And the patient will come in, and they love to come in and talk about, like, last week I was walking down my street and all of a sudden I couldn't talk, or all of a sudden I got real, feeling feeling real funny, or I had a real bad headache, or, they love to come in and just tell you like something that happened like last week or last month. That should kind of start getting you thinking TIA in the back of your mind. And they're fine now. That's kind of something that I start thinking about. Okay, could this be a TIA? Of course, we always want to talk about risk factors with our patients for stroke. So non-modifiable and our modifiables: family history, age, race. Men, you can't change your gender, your age, your race. But modifiable: smoking, hypertension, diabetes. Those are things that we can work on. For our patients, we can work together as a team. Also just sedentary lifestyle, that can contribute as well. So again, not only does it cause, diabetes or other things, but stroke is another real one that we want to pay attention to. All right, so who all remembers this one from nursing school or seen around the hospital? They had a lot of campaigns about Be Fast, and I still think it's a really great mnemonic to not only know as healthcare workers, but also to teach our patients. If they've had some sort of, episode in the past, this is something that we want to talk to them about. If they have high blood pressure or they have, AFib, this is something that I really want to talk to them about and being aware of. So B is going to stand for balance. E is eyesight, so changes in vision, changes in balance. They're unsteady on their feet. Their face is one side or the other drooping. Their arm, they'll hold their arms out completely straight. And if one of them drops, a lot of times that can be a sign. Speech, is it garbled or slurry or confused, asking inappropriate questions? And then time. Always paying attention here to time, because they need to call 911. They don't need to come into your office, because remember, brain death here. If they've had some sort of, episode, we don't want them sitting around our office or at home. We want them going to the ER so that they can get the treatment that they need, like in a timely manner. So back to ischemic strokes. Treatment here, the CT scan is going to show some sort of blockage. We're going to give them some sort of TPA, like alteplase, and it needs to be given within 4.5 hours. That's our gold standard for stroke care. Remember, these are not going to be done in primary care, but if you're working, as an FNP or acute care nurse practitioner in the ER, you may see these things. Contraindications for TPA is going to be head traumas, recent surgeries, clotting issues or anticoagulation therapy because their blood's already thin. Hypertension, also going to be a contraindication if that blood pressure is really high. They're going to do an MRI to assess damaged areas. And then a lot of times these patients are going to need rehabilitation. If they have that aphasia, if they have something like that, they're going to need intense therapy to rehabilitate. And who can tell me, after a stroke, any kind of stroke, who can tell me what is the timeline for them to regain? When do we know that they'll be back from baseline? Does anybody want to put that in the chats of when will they be back to baseline, that we can kind of tell, like how often or how long can they regain function status post-stroke? Anybody want to say there? Anybody know? Their rehabilitation time frame is going to be 12 months, okay? 12 months from the initial stroke, they can regain. And then after that time, it's more just going to be preserving their function. Okay, and reducing our risk is our goal. So lowering blood pressure, smoking cessation, lowering cholesterol, those are all going to be important factors for, prevention is going to be our number one thing here to try to prevent strokes, because once it happens, then we have damage. It's not always reversible. So hemorrhagic strokes is going to be a CT scan showing the bleed. It could be a subarachnoid hemorrhage. It could be intracerebral hemorrhages. They're going to have some sort of surgery so that they can do a clip. And again, as always, neurological monitoring, MRI to assess the damage, rehab to gain the bodily functions, and anti-seizure medications. And who can tell me if they have some sort of hemorrhagic stroke, why would we want to provide an anti-seizure medication? Does anybody have any idea there? Right. We don't want, yes, that's right. So we don't want the bleeding area to increase, and we don't want them to get a seizure. Yes. Uh-huh. Okay. So we're trying to maintain that function. Okay. All right. So subdural hematomas. All right. This can be as a result of a stroke, or somebody can just get this by having a fall, an MVA, an accident, any type of head trauma. They're going to diagnose a CT, MRI. The main thing is we're going to monitor the smaller ones. If it's a large one, they may need surgical intervention. If they've had the hemorrhagic stroke, surgical intervention. And headaches, nausea, vomiting, seizures, those are some of our symptoms. Again, very kind of vague. So these patients, are going to need some imaging done. All these neuro patients are most likely going to be headed for imaging. All right, let's talk about concussions. Those are my stroke highlights for the day. Again, we're happy to answer more of your questions on stroke because it's a very large topic that I try to condense in just a few minutes to hit the high points. So concussions, let's talk about that. Any type of brain injury, a traumatic brain injury can be a fancy word for this. They're going to have some sort of headache, dizziness, nausea and vomiting, loss of memory around the accident, pupillary changes. This is going to come always from some sort of injury. So playing ball, a wreck, like a car wreck, hitting their head, something like that. This is going to be due to an injury. We're going to check their mental status. We're going to check their level of consciousness, their balance, reflex, and a red flag is going to be clear nasal drainage. So who can tell me after somebody has bumped their head or had some sort of head injury, who can tell me why clear nasal drainage is going to be a big red flag? Who can put that there in our chats? And one other thing I just want to draw your attention to while y'all are thinking about the answer to that question is impact. Yes, that's right. Very good. CSF leakage. Absolutely. So if we start seeing clear drainage from their nose, we need to first off immediately think this could be CSF. Absolutely. Cerebral spinal fluid. Okay. So one thing I just want to draw your attention to, if you're working in pediatrics or you're working with kids a lot, there is some new testing called impact. So impact testing can be done before the kid even starts playing the sport. Okay, maybe they're going to play football, whatever it be. And it's computerized, and what they can do on impact testing is it's kind of checking their reflexes and seeing how fast their hand-eye coordination is and everything. And then if they sustain some sort of blow to the head or injury that we're suspicious about a concussion, then they can repeat that testing. And if they are having some measurable differences in reaction time or cognition, this can kind of help to monitor their status. So again, that's called impact, IMPACT. I thought that was really cool. For those of you all who work with a lot of kids, maybe you all can tell us a little bit more about it. But that's just something that I wanted just to throw there to kind of have in your back pocket if you are doing a lot of pediatrics and doing a lot of sports physicals. So meningitis, the boards and school love to test on meningitis. So just a reminder here, there are three to four types: bacterial, viral are our main ones, fungal, and then non-infectious causes. The risks for developing meningitis, it's always the immunocompromised, just like we talked about last week. If you're immunocompromised and your immune system's down, you're going to just be at more risk for a lot of things in general. Close living quarters. So again, remembering those vaccines, when those kids are going off to college, around that 16 to 18 years old, that's when we can give the vaccines. And then chronic conditions, headache, fever, nuchal rigidity, also known as neck stiffness, is going to be really important to pay attention. This is a medical emergency, guys. This is not something that, again, you're treating in primary care. This is something that you'll maybe see in primary care and then send on to the hospital to get your confirmed diagnosis. So this is just going to be a differential. A couple of the things that I want you all to is the Brzezinski sign and the Koenig sign. I have them here for you all. Bending the knee, and then bending the knee and lifting the head. So that picture right there is showing y'all how to do. And this is checking for nuchal rigidity or neck stiffness. The patient's going to have pain there. And when you bend their head there, their knees are going to just automatically curl up. These are a couple of your diagnostic tests that you can check, in the office during a routine exam, along with your neuro exam to kind of help you differentiate between meningitis, maybe something else. These patients are going to have a CT scan, they're going to have an MRI, and they're going to have a lumbar puncture done. And of course, the main thing is treatment is dependent on the cause. So, if it's viral, antiviral. If it's bacterial, antibiotics. If it's fungal, antifungals. But again, getting to the root source and finding out, what is causing this meningitis, because these patients are going to get really sick really fast and they need closer monitoring than they can have at home. So they're going to be hospitalized. Okay. This slide I told you all was coming up down the road. Who can remember what this goes with? Think about that. Remember, this is inflammation of their vasculature, specifically their temporal artery, often called giant cell arteriitis or temporal arteritis. Females over 50, this is caused by claudication in the jaw. So you can think about claudication in the legs can cause pain. They're going to have jaw pain up here when the claudication occurs in their jaw as well. They're going to have visual changes. This one also is going to get steroids. They're going to have biologics. And we're technically worried about blindness with this. So this is something, if your patient comes in, that we want to really get worked up quickly so it doesn't progress any further. Okay, so we're going to move on to questions. I know that was a lot of content in just a few minutes, but again, we have NPs here ready to talk to you about in the chat. And before I move on to the question portion, I'm going to interrupt this for just a little commercial break. The first thing I want to just draw your attention to is the upcoming live webinar. It's super exciting, coming up May 31st to June the 2nd. It's an in-depth review of those must-know topics, okay? There's going to be live instructor interaction. There's going to be a 30-day access to the recording after the fact, so you can go back, you can pause us, you can take your notes, and $50 included is all 3 days. It's going to be a full day Friday the 31st, and then that Saturday and Sunday is going to be, 9 to 1, depending on what time zone, around that time zone, or around that time, and so you'll get a little bit of weekend time in still, but we're going to be covering all body systems here. And then I put a QR code up there for you all to register for that. And then also we just want to connect with you. We really want to be supportive to you as you're preparing for boards and as you're going through your nursing programs. We really want to provide that extra layer for you of coverage, fill any knowledge gaps that you have. We are now up to over 1,550 questions in our Q Bank. We're running right now a special for a 30-day free trial. And then after that, it's $29 for 60 days. So really a great tool here that you all can be practicing those questions, okay? And that's really the main thing is, when we're studying, making sure that we not only review the material, but also practice questions in board style, finding a source for those. So Really exciting things coming up here. And then also, I just want to tell you all Happy Nurses Week coming up. It's going to be May 6th through the 10th this week, and Archer Review really wants to participate. We have all kinds of fun things coming up for everyone. We have some things like seats in our upcoming live review. We have an Archer stethoscope. We have gift cards. So we have a lot of really fun, exciting things coming up to celebrate nurses, because I know that nurses work really hard. And even if you're not an FNP yet, I know that you're working really hard as an RN. And so we just really want to celebrate you, give you a time to just kind of relax and pamper yourself. And so you need to come onto our social media, and we'll be doing a giveaway every single day next week. So lots of chances to win, lots of great prizes. Okay, let's go ahead. You all can put your questions in the chat as we go along. And then also we're going to just practice some review questions and just kind of walk through the material here. All right, so a 72-year-old man comes into primary care clinic for a hospital follow-up 1 week after a trans-ischemic attack. The nurse practitioner performs a medication reconciliation and notes that he has been taking Eliquis for atrial fibrillation over the past 2 years. Which teaching topic would be most effective for today's visit? So I want you to think about here. This question goes ahead and tells us every answer is great. They're all correct. But I want you to think about the best answer. Okay. So we're not only practicing answering the question and getting the information and the rationale, but we're also practicing our test taking strategies of process of elimination here and choosing the best answer. So bleeding precautions due to anticoagulation therapy. That's A. B, signs and symptoms of stroke. C, how atrial fibrillation affects the heart muscles. And D is how stopping smoking can lower his CVA risk. So again, all these are really great topics for your patients who's had a TIA recently. But let's choose the best answer for today's visit. So I'll give you just a minute to think about that. Very good. Spot on. Yep. B. That's right. So signs and symptoms of stroke. Remember, we talked about how TIA can be a sign of an impending stroke. That is going to, if they're having multiple TIAs, we need to get started on the lifestyle changes. We need to get started on making sure that they do have some sort of antiplatelet on board. Maybe it's, a little aspirin. This guy has Eliquis. A fib alone increases their risk of ischemic stroke. So again, these are all things he's probably already been educated on bleeding precautions because he's been on Eliquis for 2 years. Again, not a bad idea to remind him of those things. Atrial fibrillation affecting the heart muscle, knowing that it sets him up for clots. Again, very important how that works. And this question doesn't say anything about smoking on here. Of course, we're always assessing for smoking for our patients, but I don't want you to read into the question here because it doesn't say anything about him having a smoking history. So the best and most appropriate answer here is going to be B, and it's signs and symptoms of stroke. He needs to know what signs and symptoms to report, when he needs to call the ER, and his family needs to be watching him for signs and symptoms of stroke. Very good. So let's go ahead and talk about migraines here. This question is, you're counseling a 32-year-old female with a history of migraine with aura on hormonal birth control options. Which medication would you offer her? So that's going to be norethindrone or Camilla, NuvaRing, Losizinic, or Biaz. I want you to think about patients with a migraine with aura. What is contraindicated in those patients? Very good. Very good. Yes, we're going to give her norethindrone because Estrogen. That's right. All these other medications that are listed here have some sort of estrogen component, and the most safest one for this client is going to be the mini pill or a progesterone only. She can also have an IUD or an Nexplanon. We can discuss that with her as well. But anything that contains estrogen here in the hormonal birth control medications is not going to be your safest option by any means. And I would steer clear from those, especially as she's approaching age 35 here in a couple of years. We want something that's going to last her forevermore or a little bit longer. And then also the migraine with aura, that's going to be a no-go. So your best bet out of there is A. So very good. Okay. Let's talk about this one. Let's see if you all connected the dots. A 54-year-old female with a history of polymyalgia rheumatica comes in today complaining of a visual disturbance and jaw pain on the right side. Which differential diagnosis must be ruled out? So A is multiple sclerosis, B is Bell's palsy, C is trigeminal neuralgia, and D is temporal arteritis. So I'll give you just a minute to think about that. That's right. You've got it. You've got it. Absolutely D. Temporal arteritis and polymyalgia rheumatica can hold hands because they're both inflammatory processes, and that has to be ruled out. So very good. Y'all got it. All right. Let's talk about headaches. A 62-year-old male comes into the urgent care complaining of left-sided headaches with nasal congestion now occurring every afternoon. Which headache type is going to be your first differential? Okay, so this is going to be a unilateral headache, complaining of some nasal congestion, and it's occurring every afternoon. So migraine, thunderclap, cluster, or secondary. So I want you to think about your headache types and which one do you think is going to be our first differential for headache types? And bonus points if you can tell me how to treat that. What are our first line treatments for that? You can put that in our comments. Very good. Very good. That's going to be cluster. C. And we're going to treat that with calcium channel blockers and oxygen. That's going to be our first line treatments for those. Very good. All right. So this is our last question. Benji, a 1-month-old male, arrives at the clinic with a fever. His mother states he will not take his bottle at all today. Upon further examination, he cries when the pen light shines in his eyes and his fontanelles are bulging. What is your next step? So A is going to be order an x-ray of his head. B is order a complete blood cell count. C is order a straight cath urine culture. Or D, send him to the ER for further workup. Who can tell me what we need to do with this infant? That's right. Absolutely. You got it. D, he's got to go to the ER. Benji is going to the ER today. If for nothing else, he's under the age of 2 months with a fever. So all children under the age of 2 months old, little infants that are sick, especially febrile, they are going to automatically go to the ER. But then also ruling out meningitis. So it doesn't matter if Benji is 1 month old. It doesn't matter if Benji is, 2 years old. When we're complaining of fever, he won't take his bottle at all or any food in. He's fussy. He's got photosensitivity. All of those things need to tip you off to meningitis, okay? So Benji is very sick. He needs to go to the ER. He doesn't need to get anything else done in your office, and he needs to go straight over there and get further workup for meningitis. So very good. You guys got this. So again, back to knowing for your neurological things. A lot of times in primary care, we're not working these things up. We're not, treating them much. But the main thing I just want you to remember, if you remember nothing else, is knowing when to refer. That's going to be your number one thing for these neurological things. Strokes in the ER, meningitis is in the ER, MS is going to be handled by neurology, but just know when to refer, knowing what's emergent, and, when in doubt, check it out. That's my favorite saying there. So great job today, guys. Y'all made it through so much information in just a few minutes. I'm going to go ahead and just leave you here with this up for us today. I put the QR code there for you. If y'all have any questions, we're super excited to see all of you all in our live review. I hope that all of y'all will take advantage and sign up for this amazing price, for this amazing time that we can get y'all ready for boards coming up. And if there's anything else, Rachel or if Morgan's here that y'all want to add, and we hope that all of y'all win a prize next week. That's so exciting for Nurses Week. That just came out today. So new information, but do follow us online and give us, follow us on social media. We post questions there as well. So, lots of opportunities there for not only to have fun, but also maybe learn something and practice on the go. So if there's anything else that we need to wrap up, you all can put it in the chats. Otherwise, I won't keep you any longer. I thank y'all so much for hanging with me today. I know it was a lot to cover. Y'all can go back and watch this and practice some more. All right, take care. Bye-bye.